The goal of this video is to demonstrate 3 teaching learning strategies to support diverse learning styles. And today we're going to use the strategies of lecture, case studies, and concept mapping. We're talking about migraine headaches today. That's our topic, and my name is Amy Townsend. Again, teaching methods are lecture, case study, and concept mapping. The objectives for this class are to discuss the precipitating factors, clinical manifestations, and management of migraine headaches, and also to explain the nursing care and patient education for migraine headaches. Student resources include Adams, Holland, and Urban's Pharmacology for Nurses, a Pathophysiologic Approach, and Hinkle and Cheever's Bruneth and Sarda's Textbook of Medical Surgical Nursing. Headache is one of the most common of all physical complaints. It's a symptom rather than a disease itself. There can be an organic cause such as a brain tumor, or it could be a non-organic cause like a stress response, a skeletal muscle tension, or a combination of many different factors. Migraine headaches are a complex of symptoms. They are periodic and recurrent, and the pain from these headaches can last anywhere from hours to days. They're often debilitating. The exact cause of them is unclear, but they do occur more in women than in men, and they may be inherited. The pathophysiology for migraine headaches. Symptoms result from a hyperexcitability that comes from the brain during the cortical spreading depression. And during the cortical spreading depression, an inflammation response is triggered, and it stimulates the brain to cause different vascular changes like vasoconstriction, inflammation, and a continuation of a pain signal. There are many different triggers for migraine headaches: physical or emotional stress, depression, sleep deprivation, bright lights, loud noises, certain odors, smoking, skipping meals, alcohol, caffeine, hormonal changes, and some foods. There are 2 types of migraines that we're going to talk about: migraine without aura and migraine with aura. They're basically the same, except the migraine with aura comes with a preliminary phase. So the migraine without aura is a pulsatile throbbing headache that's unilateral. It lasts 1 to 2 days. It can be aggravated by any kind of routine activity, often accompanied with nausea, vomiting, increased sensitivity to light or sound, that's also called phonophobia and photophobia. And it can have visual disturbances and hallucinations along with it. These patients may see sparks or flashes of light. Now, the migraine with aura is similar to the migraine without aura. These signs and symptoms are going to be reversible. They may see flickering lights or spots. They may have loss of vision. They may feel numbness or tingling. Again, they'll have reversible speech and neurological signs and symptoms. The aura can develop over a period of 5 to 20 minutes and last less than an hour, but they have these prodromal symptoms, and prodrome is a symptom indicative of impending, something's coming on. So they have the prodromal period with this aura that precedes the attack by hours to days. So the first phase, there are 4 phases in migraine with aura. The first phase is the premonitory phase. This is going to occur days to hours before the headache comes on. The symptoms are anywhere from depression and irritability to food cravings, and then they can also have some physical symptoms that go along with that. Usually, if patients have a prodrome of symptoms, they're going to have it with every headache or every attack that they have. And these prodromes or migraines with aura are associated with 80% of all migraine sufferers. Second phase is going to be the aura phase, and this is where they have the actual symptoms like visual disturbances, flashing lights, bright spots. They can have numbness and tingling. They can be very drowsy or dizzy or have weakness of an extremity. This usually lasts less than an hour, and this is the time that you want to tell them to take the meds to prevent a full-blown attack. The third phase is a headache phase. This is where they get the severe incapacitating headache. It's unilateral in 60% of the cases. It's going to intensify over hours, and it is associated with photophobia, phonophobia, nausea, and vomiting. This phase, or the headache phase, usually lasts 4 to 72 hours. The last phase, or the prodrome phase, is where the pain gradually subsides. There may have muscle contractions in the neck and scalp. At this point, they're totally exhausted. They can have mood changes, and any physical exertion is going to exacerbate the pain. So this is when they have to go to bed and sleep for days, hours to days, to actually get rid of the pain. Now, the assessment for patients with migraine, first of all, we're going to do a detailed history. We're going to ask about precipitating or provoking factors, and we're going to have the patient describe the headache in their own words. We're going to ask things like location. Is it unilateral? Is it bilateral? Does it radiate? What's the quality of the headache? Is it dull? Is it aching? How many occur during a given amount of time? Are there any precipitating factors? Does anything make it better or worse? Does it occur during a specific time of the day? Are you taking any kind of meds for it, or do any kind of meds help it? We also want to know, are they taking any kind of medications in general, such as antihypertensive, diuretics, anti-inflammatories? Do they have a family history of migraines? And then we also want to know, have they been exposed to toxic substances? Now, the diagnostic evaluations of migraines include CT, MRI, or EMG. They can also have cerebral angiography. None of these are usually helpful because there are very few objective findings with migraine headaches. So if we do a CT or MRI, it's going to come back completely normal. Prevention of migraine headaches includes patient education, and we're going to educate patients to avoid triggers, lifestyle changes, and pharmacological measures like abortive therapy for acute attacks and then preventative meds. Prevention and education, we're going to tell them to avoid smoking, caffeine, alcohol, that we want them to do regular exercise, make sure they get enough sleep. We can tell them to relax and reduce stress. And anytime they have at least 3 headaches a month, it may be recommended that they start a preventative medication. Now, there's no significant complications that come from migraine headaches. They can be chronic, recurrent, and may interfere with day-to-day life. Stroke is an extremely rare complication. It may be due to prolonged narrowing of blood vessels. So non-pharmacological measures are things like ICE, biofeedback, which is a non-medical process that involves measuring specific body functions. It raises patients' awareness of these and possibly gives them conscious control of these functions. Also, we can teach them relaxation techniques, but it may not help them to actually abort once an attack begins. Sleep is always the best medicine for these. All right, so let's talk about pharmacologic measures. They can take over-the-counter analgesics such as acetaminophen, aspirin, NSAIDs, or they can take prescription medications like Ergos or Ergostat, triptans, Imitrex, or anticonvulsants like Topamax. Triptans are going to be the first-line drug therapy for people who suffer with migraines. And ergostats and anticonvulsants are going to be the preventative medications that they can take. All right, so now we have a case study or case scenario. I'm going to read it to you and then we'll talk about it. All right, a 31-year-old female attorney complains of sinus headaches about 3 times a month since her teens. She complains of unilateral retroorbital pressure, so it's on one side behind the eye, and it's throbbing. It's moderate to severe in intensity, and it's associated with nausea, light, and noise sensitivity. Nasal stuffiness, sometimes drainage. Headache is worse with movement. Triggers include changes in the weather, intermittencies, and she reports that her mother and 2 sisters have also had these headaches. Over-the-counter medications may dull the pain. Headaches last about 24 hours and may require bed rest. Medical history is otherwise negative, except for history of mitral valve prolapse, frequent anxiety, and panic attacks. So what is our diagnosis for this case study? Migraine. So how did we arrive at this diagnosis?
Weather change.
Weather may cause a change.
Light noise sensitivity.
Light and noise sensitivity. What else?
Stuffiness, nasal stuffiness, sometimes nasal drainage.
Okay.
Um,
Any other triggers?
Headache is worse with movement.
Worse with movement. Menses are hormonal changes.
Yes.
It talks about her mother and two sisters having, so it may be inherited. What was the clinical manifestation that was characteristic of a migraine? Unilateral pain, so on one
Goes
side.
on one side, not the eye.
And it says it occurs about 3 times a month, so we may want to tell her that she could be a candidate for preventative medication, right? What other preventative medications could we tell her, or measures could we tell her to take?
Ice.
Ice, what else?
Triptan.
Triptans, that's gonna be a pharmacological, but very good, because that's the first line to abort an attack.
Get rest.
Get plenty of rest, avoid foods like what?
Chocolate.
Chocolate,
Coffee.
Smoking.
coffee or caffeine, smoking, alcohol. All right, so what kind of diagnostic testing should we get?
MRIs.
CT or MRI, what's it gonna show us?
There's nothing.
It's gonna be normal, right? All right, so if we were to educate this patient about migraine headaches, what else would we tell her?
Work out. Have a daily
Regular exercise may help it,
Plenty of rest.
plenty of rest,
Watch what she eats.
that's right, watch what you eat,
Lifestyle changes.
lifestyle modifications. All right, so this is a migraine headache concept map. It's gonna talk about migraines with auras, and we're gonna talk about the patho and clinical findings again. There's no known root cause, but we do know about the cortical spreading depression, and that creates the auras. It also causes all the other clinical manifestations that go along with the migraine headaches. So I encourage everyone to develop their own concept map for migraine headaches. Now, is there any questions? Done.